Evaluation of the impairment of the respiratory system should be conducted according to the instructions set out in the text of the 4th edition of Guides to the Evaluation of Permanent Impairment. The purpose of using the guides is to provide an objective framework that allows 2 or more physicians to agree on the extent of impairment, usually expressed as a percentage of loss of function of the whole person. Although it is important to use the tables provided in the book to determine this percentage of impairment, one cannot come to a valid conclusion without using the methods and cautions described in chapters 1 and 2 of the book. These chapters must be read and understood before any rating of impairment is made. Some of the underlying concepts to be kept in mind as we proceed through the evaluation of permanent impairment of the respiratory system include the following. First, previous medical evaluations should be obtained and reviewed by the physician making the impairment rating. This allows the physician to understand the reasons that the evaluation is being conducted and provides medical background data on the patient. Second, the condition being evaluated should be stable, fully treated, not amenable to medical or surgical treatment, and should be expected not to change for at least 12 months. The reason for this requirement is that we are attempting to evaluate the patient's functional status after all expected medical improvement has occurred. Finally, clinical examination by the evaluating physician should be similar to the information provided in the medical records. If there's great disparity between the evaluation by other physicians and by the physician doing the permanent impairment rating, the reason for the disparity must be understood and reconciled before the final rating is made. It is very helpful for the physician performing the impairment evaluation to use the report form provided on pages 11 and 12 of the 4th edition of the guides. This form helps the physician integrate all the available information into a final assessment judgment. As a general concept, evaluation of the respiratory system is aimed at determining how an injury or disease process has altered the individual's ability to function in the everyday world. Several principles are important in making this evaluation. Keep in mind that there is substantial redundancy in the amount of pulmonary parenchyma available to the normal individual. The fact that an individual can function reasonably normally following pneumonectomy should underscore that fact. I'm not implying that the person who has undergone pneumonectomy should be considered to have normal pulmonary function, but only that moderate amounts of lung tissue can be lost to a disease process without adversely affecting the individual's ability to function in the everyday world. Also, keep in mind that cardiopulmonary limitation to exercise is commonly affected more by cardiac than by pulmonary considerations. By this I mean that when a person with normal pulmonary and cardiac function exercises maximally, there is enough redundancy of the lung tissue so that cardiac function rather than pulmonary function will limit the vigor or duration of the exercise. Once again, this implies that minor to moderate alterations in the pulmonary parenchyma will have little or no effect on the individual's ability to function in the everyday world. Finally, abnormalities that can be visually identified, for instance, on a chest radiograph, frequently do not translate into a functional impairment. It is quite common for a chest radiograph to show evidence of pneumoconiosis without identifying any significant change in the pulmonary function. While the physician performing the impairment evaluation has a responsibility of recognizing that a pneumoconiosis is present, the impairment rating should take into consideration only the effect that the abnormality has on functional ability and should not take into consideration a visual abnormality alone of the contents of the thorax. It might be useful at this point to consider the general types of pulmonary abnormalities that lead to permanent impairment of lung function. They fall into three main categories, as shown in Table 3. By far, the most common abnormality is obstructive lung disease of the type usually associated with cigarette smoke. Chronic obstructive lung disease has two subcategories, consisting of chronic bronchitis and emphysema. Frequently, these two subcategories coexist because they are produced by the same etiologic agent, in this case, cigarette smoking. Emphysema is defined by anatomic criteria describing damage and subsequent disappearance of some of the alveolar walls, leading to enlarged air spaces within the pulmonary parenchyma. The loss of lung tissue results in more space available within the thorax for air, less resilience of the lung tissue, leading to decreased ability to expire air from the chest and air trapping, as well as decreased surface area available for gas exchange. Chronic bronchitis, on the other hand, is defined on clinical grounds, such as cough and sputum production on most days for 3 successive months for at least 2 years in a row. This disease is based in the bronchi rather than in the alveoli and produces obstruction only when the volume of mucus production overwhelms the ability of the individual to clear the respiratory tract effectively by coughing. Acute but recurrent obstructive disease is caused by asthma. This is an inflammatory disease that produces recurrent bronchospasm, often affecting the individual's ability to function in a reliable manner in a work setting. The next most common type of pulmonary abnormality producing permanent impairment is pulmonary fibrosis. A wide variety of diseases can lead to pulmonary fibrosis, including work-related abnormalities such as pneumoconiosis or chemical injuries to the lung, idiopathic diseases such as collagen vascular disorders, and idiopathic pulmonary fibrosis. Whatever the cause of pulmonary fibrosis, the functional effect is the same and is characterized by an increase in the tissue contents of the thorax that decreases the space available for air within the lung and decreases the efficiency of gas exchange. A less common but no less devastating pulmonary function impairment can be caused by pulmonary vascular obstruction as a result of chronic recurrent pulmonary emboli leading to pulmonary hypertension. The functional effect of pulmonary vascular disease is to interrupt the normal balance between ventilation of the lung and perfusion through the pulmonary vessels. The patient affected by this abnormality will have a decrease in the parameters of gas exchange and will experience hypoxemia. To summarize the abnormalities we will be rating according to the guides to the evaluation of permanent impairment, the next figure shows characteristic tissue slides, chest x-rays, and pulmonary function test results for examples of a normal person, a patient with chronic obstructive pulmonary disease, a patient with pulmonary fibrosis, and a patient with chronic vascular obstruction due to recurrent pulmonary emboli. The first panel shows normal pulmonary parenchyma with thin alveolar walls and intimate contact between the alveolar air and the pulmonary capillaries. The alveoli are of roughly equal size throughout the lung tissue specimen. The chest X-ray shows normal aeration and normal blood vessel density. Pulmonary function studies show normal forced vital capacity, normal FEV1, and normal ratio of FEV1 to FVC, as well as normal diffusing capacity. The second panel shows a patient with emphysema. The tissue is characterized by irregularity of the size of the alveoli, with loss of alveolar walls and a decrease in the numbers of pulmonary vessels in contact with the alveolar air. The chest X-ray shows hyperinflation of the chest with too much air and too little lung tissue. Pulmonary function studies show a decrease in the forced vital capacity since airways obstruction leads to an inability to exhale the trapped gas from the chest. Airflow rates are greatly diminished and show a decrease in the FEV1 and the ratio of FEV1 to FVC. The diffusing capacity is also diminished because destruction of the alveolar walls has led to a decrease in surface area available for gas transfer between the alveolar space and the pulmonary capillaries. The next panel shows a patient with pulmonary fibrosis. The tissue sample shows thickening of the alveolar capillary membrane with loss of space available for air within the lung. There is also an increased distance for oxygen to travel across the alveolar capillary membrane when compared to the normal lung. The chest X-ray shows increased interstitial lung markings throughout the pulmonary parenchyma, but particularly at the lung bases. Pulmonary function studies show a decrease in forced vital capacity because the fibrosis has displaced air from the lung. The FEV1 is diminished because of the decrease in FVC, but the ratio of FEV1 to FVC is normal since the bronchi are not affected by the process. The diffusing capacity is diminished because diffusion takes place more slowly across the thickened alveolar capillary membrane. The last panel in the series shows very abnormal pulmonary vessels as a result of chronic vascular obstruction. Although the pulmonary parenchyma itself is relatively normal, the blood vessels have become thickened as a reaction to the sustained increase in pulmonary arterial pressure. The chest X-ray is relatively normal, but in some cases shows enlargement of the right ventricle. Pulmonary function studies show normal forced vital capacity, normal FEV1, and a normal ratio of FEV1 to FVC. The diffusing capacity is diminished since blood flow does not take place normally through the pulmonary parenchyma. Other, less common causes of pulmonary impairment and other, more specialized means of evaluating impairment will be discussed later in this presentation. It should be clear from this background discussion that there are two phases in the evaluation of permanent impairment of the respiratory system. The first phase is a diagnostic phase, and the second phase is quantitative. The diagnostic phase investigates the type of disease process being assessed and integrates it with all previous medical evaluation that is available to the physician performing the rating. As we discuss the diagnostic phase over the next few minutes, Please keep in mind that although there is only a small amount of quantitative information provided, the physician must understand the nature of the disease process in order to come to valid conclusions regarding its severity. As in most physician-patient interactions, the patient's description of specific complaints is the starting point for the assessment. Personal habits, such as cigarette smoking and workplace exposures to potentially toxic substances, are important parts of the assessment of the respiratory system. The most commonly described symptom is dyspnea, but this is a very nonspecific complaint. It's also very difficult to quantify a subjective symptom such as dyspnea. The most widely used classification of dyspnea is shown in the next table and was proposed by the American Thoracic Society. The lowest level of physical activity and exertion that produces breathlessness denotes the severity of dyspnea. A positive response to the physician's question, "Do you have to walk more slowly on the level than people of your own age because of breathlessness?" indicates that the dyspnea is mild. A moderate amount of dyspnea would be characterized by positive response to the question, "Do you have to stop for breath while walking at your own pace on the level?" Severe dyspnea would be indicated by a positive response to the question, "Do you ever have to stop for breath after walking about 100 yards or a few minutes on the level?" Very severe dyspnea would be indicated by a positive response to the question, "Are you too breathless to leave the house or breathless after dressing or undressing?" Please note that if there is a great disparity between the subjective symptom of dyspnea and the objective findings on pulmonary function testing, a non-respiratory component of the dyspnea should be suspected. Cough, sputum production, and hemoptysis are also important symptoms of respiratory tract disease, but are even more difficult to quantify than is dyspnea. Most patients who complain of intermittent wheezing carry a diagnosis of asthma. While their pulmonary function studies may be grossly abnormal during an attack, they may be normal or near normal between attacks. The frequency and severity of attacks are important indicators to the rating physician as to the impairment caused by the disease. Other important information about wheezing that should be gathered during the history taking relates to symptomatic triggers of wheezing, such as exposure to chemicals, allergens, cigarette smoke, or change of season. A history of cigarette smoking is the most common cause of obstructive lung disease, and the physician should quantify the duration and intensity of smoking by asking about the age at onset of smoking, age at quitting, current age, and the number of packs smoked per day. From this information, the standard measure of smoking, called pack years, can be calculated by multiplying the number of packs smoked per day by the number of years of smoking. There are no hard and fast rules regarding the number of pack years accumulated and the severity of obstructive lung disease. Even so, we seldom see severe obstructive lung disease due to cigarette smoking with less than 20 pack years of accumulated smoking. Keep in mind that the smoking history a patient gives, like the history of alcohol intake or the quantity of the family's income, may not be accurate. A medical history used for evaluation of permanent impairment cannot be considered to be complete without a full occupational history, since environmental exposures in the workplace are often cited as causative or contributory factors in the development of respiratory impairment. Table 5 shows the requirements for a valid occupational history. They include a chronologic listing of jobs held throughout the individual's life, citing the duration of employment and the specific duties performed. Specific exposures to potentially injurious materials found in each workplace should be noted, along with an estimate of the frequency and intensity of exposure to each substance. Finally, the history should state whether or not respiratory protective devices were used and whether or not they were used on a regular basis. Physical examination is also important to the diagnostic phase of evaluation. Factors such as body habitus, breathing pattern, use of accessory muscles of respiration, and pursed lip breathing are helpful in validating the stated severity of respiratory symptoms and should be correlated with the quantitative assessment we will be discussing later. Visual inspection of the chest can identify rib cage or vertebral abnormalities that give evidence of obstructive or restrictive lung disease. For instance, a patient with barrel-shaped deformity of the chest is likely to have obstructive lung disease on pulmonary function testing, whereas the patient with kyphoscoliosis can be expected to have restrictive physiologic factors. Auscultation of the chest also gives diagnostic information in that decreased breath sounds or expiratory wheezing indicates the presence of obstructive lung disease, whereas persistent inspiratory crackles occur in 2/3 of patients with chronic interstitial lung disease and may suggest the presence of a restrictive abnormality. Before leaving the subject of auscultation of the chest, it is important to remember that bronchospastic obstruction to airflow is commonly missed by the examining physician when observations are made only on quiet breathing. Much better diagnostic accuracy is obtained when the physician listens to the chest during forced expiration. Inspiratory wheezing is frequently an indicator that the sound is being generated in the upper airways, at the glottis or subglottic area, rather than in the bronchi. While anatomic upper airway narrowing clearly causes obstruction to airflow, the diagnostic implications and the approach to therapy are quite different than in chronic obstructive lung disease. Voluntary constriction of the upper airways during examination can produce either inspiratory or expiratory wheezing and can often be differentiated from bronchospastic wheezing by listening to the chest with only one of the stethoscope earpieces placed in the ear canal, while the opposite earpiece rests behind the ear on the examiner's neck. Other physical signs, such as cyanosis or digital clubbing, are of limited diagnostic value for a variety of reasons. For instance, the recognition of cyanosis is affected by the lighting within the examination room, anemia, and skin pigmentation. Digital clubbing is usually thought of as being caused by pulmonary fibrosis, even though many other diseases can produce that abnormality, including bronchiectasis, bronchogenic carcinoma, pleural tumors, lung abscesses, empyema, and cyanotic congenital heart disease. In addition, digital clubbing is often a hereditary variation that does not denote any cardiopulmonary disease. Chest radiographs are helpful in the diagnostic phase of evaluation, but add very little to the quantitative assessment of the patient's respiratory capability. Still, it is important to classify the type of abnormality being assessed in order to integrate the information with the physiologic results that will be discussed in just a moment. For instance, if the clinical examination and appearance of the chest radiograph are those of obstructive lung disease, and the physiologic abnormalities appear to be those of restrictive disease, a thorough re-evaluation of the test data should be undertaken. Once again, only chronic changes in the chest should be taken into consideration in the evaluation of permanent impairment. If there appears to be an acute abnormality, such as pneumonia or pneumothorax, the patient must be instructed to return for evaluation at a later date. Chronic pulmonary parenchymal abnormalities are most likely to produce impairment if the changes are diffuse rather than focal. Chronic obstructive lung disease is characterized radiographically by flattening of the diaphragm, vascular attenuation within the pulmonary parenchyma, increased anteroposterior diameter of the chest, and increased retrosternal airspace. While these abnormalities are frequently seen in patients with chronic obstructive pulmonary disease, it is inappropriate to judge the level of impairment on the basis of a chest radiograph. In fact, there is no correlation between the ability to work and the appearance of hyperinflation of the chest. Fibrotic abnormalities in the pulmonary parenchyma can be caused by a variety of occupational and non-occupational diseases. They generally take the appearance of either linear fibrotic streaking or rounded nodular opacities. Linear streaking, particularly when it occurs at the lung bases and is associated with pleural thickening or pleural plaque formation, is highly suggestive of asbestosis. Small, rounded opacities in the upper lung zones of individuals who have been exposed to silica dust or coal mine dust suggests that the individual has silicosis or coal workers' pneumoconiosis. A standard classification system for judgment of the severity of radiographic changes due to pneumoconiosis has been developed by the International Labor Organization, or ILO. According to this system, both the type of opacity present and the profusion of opacities within the pulmonary parenchyma are judged against standard films provided by the ILO. The location, type, and profusion of the opacity is recorded on direct comparison of the patient's films with the standard films. Pleural abnormalities are also recorded according to the ILO system. These two standard ILO films show the difference between a mild or Category 1 profusion of linear interstitial fibrosis and a severe or Category 3 profusion. Notice that the linear or reticular abnormalities are thicker and more profuse with progression from Category 1 to Category 3 film. The next figure shows rounded interstitial opacities. The radiograph on the left side shows mild or Category 1 profusion, while the film on the right side shows severe or Category 3 profusion. Unfortunately, despite the objective nature of the ILO classification system, the correlation between radiographic severity of changes and physiologic measures of impairment is really quite poor. In other words, even though an individual may have radiographic abnormalities diagnostic of a specific occupationally related condition, it is the physiologic assessment that dictates the percentage impairment of the whole person. We will use this to classify functioning as no impairment, mild impairment, moderate impairment, or severe impairment. The same statement can be made about non-occupationally related or non-environmental physical abnormalities, such as kyphoscoliosis. The physical functioning of the individual takes precedence over the anatomic appearance of the disease. Having recognized the importance of the first, or diagnostic phase of evaluation, we will now turn our attention to the second, or quantitative phase. This involves measurement of the individual's pulmonary function through formal testing methods. It is important to recognize that not all commercially available pulmonary function test equipment is satisfactory for rating impairment according to the AMA guidelines. The equipment must conform to the standards and be calibrated according to the techniques described in the 1987 American Thoracic Society Statement on Standardization of Spirometry. This statement can be found in the American Review of Respiratory Disease, 1987, Volume 136, pages 1285 through 1298. Spirometry is performed by collecting at least 3 maximum forced expiratory efforts and measuring the forced vital capacity, or FVC, the forced expiratory volume in 1 second, or FEV1, and calculating the ratio of these two measurements, the FEV1 as a percent of FVC. It is to be expected that there will be slight variations among the test efforts. However, in order for valid testing to have been performed, the 2 best FVC measurements should correlate within 5% of each other. The best measurement of FVC and the best measurement of FEV1 should be chosen to calculate the ratio of FEV1 to FVC, even if these measurements occurred on different expiratory efforts. Remember that in assessing the patient for respiratory impairment, we are not looking for an average of the test results, but rather the best effort that the patient can produce. Also remember that 3 test efforts is the minimum number acceptable for valid assessment. Most pulmonary physicians agree that if the patient cannot provide reproducible results within 7 test efforts, that the testing session should be terminated and repeated at a later time, because fatigue is likely to interfere with additional forced expiratory efforts. If wheezing has been heard on physical examination, or if the ratio of FEV1 to FVC is below 0.7, the spirometry should be repeated after administration of an inhaled bronchodilator. Whichever of the tests shows the best FEV1 and FVC, either before or after bronchodilator administration, should be the one used to determine the presence or absence of permanent impairment. The way these spirometric values are used to determine an impairment depends on comparison of the patient's best FVC and FEV1 with values obtained from healthy subjects in large reference populations. Results from many different reference populations have been published in the medical literature, and they are generally reported as normal values for a particular sex, age, and height. The 4th edition of the Guides to the Evaluation of Permanent Impairment contains predicted values for FVC and FEV1 in men and women from age 18 to 74 and from heights of 146 centimeters to 194 centimeters. These charts appear on pages 156 through 159 of the 4th edition of the Guides. While the FVC provides a dynamic measurement of lung volume and FEV1 assesses airflow dynamics within the bronchi, another aspect of lung function is indicated by the diffusing capacity measurement. An assessment of diffusing capacity is a requirement for physiologic testing of the respiratory tract in order to come to valid conclusions about the percent of permanent impairment. It measures the efficiency of gas transfer across the lung and provides unique information which is fundamentally different than that provided by spirometry. A single breath diffusing capacity measurement technique should be used and should be standardized according to the methods described by the American Thoracic Society in the same volume of the American Review of Respiratory Disease referred to earlier. While the diffusing capacity measurement is an important and useful piece of information regarding lung function, it is clear that many non-pulmonary factors are important in interpreting the results. For instance, recent cigarette smoking can adversely affect the measurement in that carbon monoxide, which is the test gas used in the diffusing capacity measurement, is also a constituent of cigarette smoke and can preload the patient's bloodstream before the measurement is made. This will falsely decrease the measured value of diffusing capacity. Another non-pulmonary factor that adversely affects the diffusing capacity measurement is the presence of anemia. In this circumstance, the number of red blood cells available for capturing the test dose of carbon monoxide is decreased, and the diffusing capacity measurement will be spuriously lowered. In a similar way, various cardiac abnormalities that change the pulmonary capillary blood volume can also affect the diffusing capacity measurement. As a final caveat on the use of diffusing capacity measurement, I should note that minor decreases in diffusing capacity occur in asymptomatic persons and do not decrease their ability to work. In fact, exercise-induced hypoxia rarely occurs when the diffusing capacity is greater than 60% of the predicted value. Having stated these warnings, I note that the diffusing capacity is a useful evaluative tool when it is used with care and understanding. The results obtained in testing an individual should be compared with predicted normal values shown for men and women of various ages and heights on pages 160 and 161 of the 4th edition of the guides. Percent of predicted can then be calculated from the measured number of the test subject and the predicted value in the table. Occasionally, it is important to differentiate between exercise intolerance due to poor physical conditioning and exercise intolerance due to cardiac or pulmonary disease. Measured exercise capacity testing can help make these differentiations in equivocal cases. Since exercise testing is more difficult, more expensive, and sometimes more invasive than the standard methods I have already described, it should rarely be used for assessment of impairment and should be reserved only for cases where there is an unresolved question as to the nature or severity of the impairment. It should not be used when the pulmonary function tests are normal or severely abnormal, and of course, it should not be used if the exercise would put the patient in danger from medical conditions such as unstable cardiac disease. Exercise testing itself measures oxygen uptake at maximal exercise tolerance. The results can be expressed either as oxygen consumption in milliliters per kilogram per minute or in METs, which is a standard unit of expended energy equal to 3.5 milliliters per kilogram per minute. Using the quantitative methods of evaluation we have just discussed, it is possible to develop criteria for various levels of impairment. This table shows the criteria for Class 1. Class 1 indicates that there is no impairment of the respiratory tract. It requires that the forced vital capacity and the FEV1, as well as the ratio of FEV1 to FVC, are all within the normal range. Please note that as long as the diffusing capacity, or DCO, is equal to or greater than 70% of the predicted, no functional impairment of the individual can be implied. Alternatively, the maximum oxygen uptake listed under Class 1 would indicate that the individual could perform very heavy work without difficulty. Mild impairment of the respiratory tract is defined as 10 through 25% impairment of the whole person and is listed in the next table under Class 2 impairment. This requires that there be a mild decrease in the forced vital capacity, or that the FEV1 be mildly decreased, or that the diffusing capacity be measured between 60 and 69% of predicted. Patients would fall into this category if any of the criteria listed under Class 1 fell below the limits stated in that classification. It would not be necessary for more than one of the criteria of Class 2 to be met before mild impairment were diagnosed. Alternatively, maximum oxygen uptake, measured as falling between 5.7 and 7.1 METs, indicates a slightly reduced work capacity to a level that is generally considered heavy work. Moderate impairment of the whole person is designated Class 3 impairment and indicates 26 through 50% impairment. This requires that the forced vital capacity be reduced to a level between 51% and 59% of the predicted, or that the FEV1 be reduced to a level between 41% and 59% of predicted, or that the diffusing capacity be reduced to between 41% and 59% of predicted. Once again, only one of these criteria need be met before assigning the individual to Class 3. Alternatively, a maximum oxygen uptake of 4.3 to 5.7 METs indicates that the individual could do only moderate work and would be assigned to Class 3 impairment. Severe impairment indicates a 51 to 100% impairment of the whole person and is designated as Class 4 impairment. Individuals in this class have a forced vital capacity less than 50% of predicted, or have an FEV1 less than 40% predicted, or a diffusing capacity less than 40% of predicted. Alternatively, they have a maximal oxygen consumption in a range that only allows light to moderate work. A few examples of patients presenting for impairment evaluation might be helpful in clarifying the use of the tables I have just presented. The first patient is a 72-year-old man whose chest X-ray will be shown in a moment. He began working as a machinist at a shipyard in 1941 and was exposed to asbestos on a regular basis while he worked aboard various ships. For the next 21 years, he worked in the boiler rooms of various food manufacturers and was exposed to asbestos when he ripped off insulation in order to repair the boilers. He had accumulated a 16-pack-year history of cigarette smoking prior to his discontinuation of that habit at age 32. On physical examination, inspiratory crackles were heard at both posterior lung bases. There was no clubbing or cyanosis of the digits. Chest X-ray shows bilateral pleural plaque formation with calcium deposition in the pleural plaques on the right hemidiaphragm, the right side of the mediastinum, lateral chest walls, and the left side of the pericardium. He also has increased interstitial lung markings that are particularly prominent in the mid and lower lung zones. His pulmonary function studies show that the forced vital capacity is 76% of the predicted value, and FEV1 is 92% of predicted. The ratio of FEV1 to FVC is 82%. the diffusing capacity is 58% of the predicted value. These studies, taken as a whole, indicate that he has asbestosis. Comparison of his pulmonary function studies with the criteria presented in the previous tables shows that his forced vital capacity is mildly reduced and falls within Class II criteria, or mild impairment. The FEV1, measured at 92% of predicted, is normal. The ratio of FEV1 to FVC is normal at a calculated level of 82%. The diffusing capacity is measured at 58% of predicted and falls into the Class III category of moderate impairment, which dictates that the diffusing capacity falls between 41% and 59% of predicted. Final classification is made on the basis of the worst of the rated studies, which means that this patient would carry a Class III impairment of the whole person with regard to respiratory disease. On the other hand, there is some disparity among the results we have just reviewed. Turning back for a moment to the table of classification of respiratory impairment, there is an important guide's footnote that requires further attention. It says that diffusing capacity is primarily of value for persons with restrictive lung disease in classes 2 and 3. If the FVC, FEV1, and ratio of FEV1 to FVC are normal, and the diffusing capacity is between 41% and 79%, then an exercise test is required. In the case we are discussing here, however, the forced vital capacity was measured to be 76%, which is in the mildly reduced range. Since the FVC is below normal, the footnote does not apply to our patient, and the exercise study does not have to be performed. On the basis of the classification, then, we can judge his impairment to be somewhere between 26 and 50% of the whole person. Since the diffusing capacity is in the upper range of the listed values, and since the remainder of his studies are either normal or near normal, his final impairment rating would be 26%. The next case is that of a 56-year-old man who began working at a basket factory in 1957 and continued that work for 2 years. From 1959 to 1965, he worked for a shipbuilding company as a pipe fitter's helper and was exposed to asbestos in the course of his work. From 1965 to 1993, he worked at another shipyard as a pipe fitter and was again exposed to asbestos. He has been a lifelong non-smoker. He complains of shortness of breath on exertion, but was unable to quantitate his exercise tolerance. On physical examination, no crackles were heard in the lungs, and there was no clubbing or cyanosis of the digits. His chest X-ray shows bilateral pleural plaque formation along the lateral chest walls, on the left side of the pericardium, and on both sides of the diaphragm. There is calcium deposition in the pleural plaque on the left hemidiaphragm. The pulmonary parenchyma shows no radiographic evidence of fibrosis. His pulmonary function studies show that the forced vital capacity is normal at 82% of the predicted value. The FEV1 is normal at 94% of predicted, and the ratio of FEV1 to FVC is also normal at 84%. The diffusing capacity is measured at 74% of the predicted value. From a diagnostic standpoint, this man clearly has asbestos-related pleural changes. Comparison of his pulmonary function test results with the table of classification of respiratory impairment reveals that his forced vital capacity falls within Class I of equal to or greater than 80% of predicted. His FEV1 is equal to or greater than 80% of predicted. His ratio of FEV1 to FVC is equal to or greater than 70%, and his diffusing capacity is equal to or greater than 70% of predicted. Therefore, according to the guides, he should be rated as 0% impaired. The next patient is a 77-year-old man who complained of shortness of breath on minimal exertion, dry cough, and ankle edema. He estimated his exercise tolerance to be the ability to walk 10 feet on level ground. His smoking history consisted of 2 packs of cigarettes per day for 50 years, which translates into a 100-pack-year history of smoking. His occupational history consisted of working in a leather tanning factory from 1933 to 1951, military service from 1942 to 1945, and work as a mechanic from 1951 to 1980. He had been using supplemental oxygen at home for 1 year prior to his examination. On physical examination, there was a barrel-shaped deformity of his chest. His diaphragm moved poorly on deep inspiration. Decreased breath sounds were noted throughout the lung fields, and the cardiac sounds were greatly diminished. There was no clubbing or cyanosis of the digits. His chest X-rays show hyperexpansion of the chest with flattening of both hemidiaphragms and pulmonary vascular attenuation. Bullous changes are noted at both apices. The remaining pulmonary parenchyma is compressed toward the bases. His pulmonary function studies show that the forced vital capacity is diminished to 46% of the predicted value. The FEV1 is 22% of predicted, and the ratio of FEV1 to FVC is 31%. He was unable to perform the diffusing capacity maneuver. From a diagnostic standpoint, this man has emphysema. Comparison of his pulmonary function test results with the table on classification of respiratory impairment shows that he clearly falls into class 4, or severe impairment of the whole person. The severity of his abnormality would place him about 90% impaired. At this point, we might spend a moment discussing arterial blood gas analysis. This method of evaluation has several disadvantages when compared to spirometry and diffusing capacity measurements. Of course, it's much more invasive than pulmonary function testing, requiring an arterial puncture. In addition, in patients with obstructive lung disease, the FEV1 correlates better with exercise capacity than does the arterial PO2. A variety of non-pulmonary factors can affect the arterial PO2 and are as diverse as the altitude at which the sample is obtained, the patient's obesity, or even breath holding by the patient. Non-pulmonary disease factors, such as congestive heart failure, can also adversely affect the arterial PO2. Having recognized all these problems with using arterial blood gas analysis in the evaluation of permanent impairment, certain circumstances still exist in which the information can be useful. If arterial blood gas analysis is performed at sea level, with the patient breathing room air at rest, an arterial PO2 of less than 60 millimeters of mercury is evidence of severe impairment as long as the patient also has one or more of the secondary conditions related to arterial hypoxemia. These would include pulmonary hypertension, cor pulmonale, increasingly severe hypoxemia during exercise testing, or polycythemia. An arterial PO2 of less than 55 millimeters of mercury in a resting patient breathing room air at sea level is, by itself, strong evidence of severe impairment. There are a number of pulmonary diseases that do not lend themselves easily to the strict pulmonary function criteria we have been discussing. One such disease is asthma, which characteristically produces intermittent incapacitation even though the patient may have normal or near normal pulmonary function test results in between attacks. Some of these patients can be judged to be severely impaired if they are receiving optimum therapy and still have pulmonary function test results in the Class 4 or severe impairment range on 3 successive tests performed at least 1 week apart. It is much more difficult for the physician to judge the level of impairment if pulmonary function test abnormalities are less severe than I have just stated. Even so, permanent impairment can be diagnosed if the patient has very frequent, severe attacks, even if the pulmonary function test results are normal or near normal in between episodes. In cases in which the circumstances of employment are suspected of producing asthmatic attacks, spirometric testing should be performed before and immediately after the work shift on at least 3 occasions to document the adverse effect of the workplace environment. It is important to recognize that while some patients have asthma in a specific occupational setting, this does not necessarily indicate that he or she has permanent pulmonary impairment in occupational settings other than those causing the abnormality. Another type of respiratory disorder that does not lend itself easily to quantification by pulmonary function testing or measured exercise testing is a group of diseases characterized by sleep apnea and hypoventilation. Sleep apnea syndromes occur in 2 varieties, the first being obstructive sleep apnea and the second being central sleep apnea. Obstructive sleep apneas usually occur in obese individuals whose upper airways relax enough during sleep to obstruct the flow of air into and out of the lungs. This produces a cessation of effective breathing until the hypoxic and hypercapnic stimuli to breathing interrupts the patient's sleep, and he or she awakens with a snorting type of reestablishment of breathing. Interference with sleep architecture and inability to achieve REM sleep produces daytime somnolence, personality changes, and poor functioning during daytime activities. Central sleep apnea is a neurologic abnormality characterized by brief episodes of sudden cessation of drive to breathing. Sleep architecture is again disturbed, despite the fact that obstruction to airflow may not be present. In both obstructive and central sleep apnea, pulmonary function tests and arterial blood gas analysis performed during the day may be perfectly normal. Nonetheless, the patient is clearly impaired with regard to functioning as a result of respiratory tract disease. The obesity hypoventilation syndrome is caused by massive obesity of the chest wall that makes respiratory movements difficult enough for the patient so that maintenance of normal arterial blood gases, even during waking hours, is impossible. Differentiation of these abnormalities is best performed in a specialized sleep laboratory that is equipped to monitor simultaneously the breathing pattern, electroencephalogram, pulse oximetry, and electrocardiogram. Many patients who have sleep apnea and hypoventilation syndromes can be effectively treated, but until such treatment has been proven to be effective for that specific individual, he or she must be judged to be severely impaired. Finally, all persons with lung cancer are considered to be severely impaired at the time of diagnosis. If the patient is treated and is found to be free of all evidence of tumor 1 year later, he or she should be rated according to the physiologic standards we have previously discussed. Recurrence of tumor at any time reestablishes the designation of severe impairment. A number of questions frequently arise in the workers' compensation occupational medicine context when dealing with respiratory disorders. It would be worth spending a few minutes dealing with some of the difficult issues. For instance, how should a physician rate respiratory impairment when the patient is suffering from other impairments as well? The answer can be found on page 322 through 324 of the guides. These pages show a combined values chart that indicates that each system impairment should first be rated individually. The percent of impairment of one system should be located on the vertical axis of the chart, and the percent impairment of the other involved system should be located on the horizontal axis. Where the vertical and the horizontal axes intersect, the combined impairment rating can be found. If 3 or more body systems are impaired, successive combined ratings should be located on the vertical axis, and the next system to be evaluated should be located on the horizontal axis. Another common question facing the examining physician is what to do when the medical history given by the patient is not consistent with the clinical findings. In the context of legal hearings and litigation, this is a very common occurrence. The responsibility of the examiner is to gather all available medical data and come to a judgment regarding impairment that is as reproducible as possible among physicians. In this case, objective data is much more reliable than subjective descriptions of illness, and numerical test results should take precedence. Even in difficult situations to evaluate, such as asthma, simple pulmonary function data, such as peak flow measurements, will be helpful in coming to a supportable conclusion. Even when the physician uses all the objective data available, there are many situations in which uncertainty remains. Under what circumstances can the physician exercise his or her discretion in rating respiratory impairment? Part of the answer lies with the broad span of percent impairment covered by each of the categories of Class 2, Class 3, and Class 4. The physician must use his or her judgment on placement within each category on the basis of the overall appearance of the patient. On the other hand, sometimes the objective data simply does not cover the type of abnormality being described. An example of this situation would be the individual who has obstructive sleep apnea syndrome that is under treatment. The physician must use judgment to evaluate the residual stable impairment during treatment. It should be stated, however, that most impairment can be measured objectively. If the physician finds a great disparity between objective and subjective findings, what should be done? In some circumstances, the answer will be to perform more sophisticated tests, such as exercise evaluation, ventilation perfusion lung scan, or pulmonary angiography. Each of these tests should be used quite sparingly, and only when the physician believes that the routine data does not give a fair picture of the patient's actual clinical status. If all data points to absence of impairment, the patient's protestations cannot be accepted at face value. Finally, it is important to recognize when abnormal objective data may not be an accurate reflection of abnormal physiology. In other words, what signs would indicate that a patient is not fully cooperative with physiologic testing procedures? Some signs are easy to spot, such as inconsistent results on serial testing of pulmonary function. Similarly, if the patient is instructed to give a forced expiratory maneuver, and the test curve shows hesitation in the course of expiration, that test trial should be thrown out. Many such test results from a patient would indicate poor cooperation with the test procedure. With regard to diffusing capacity measurement, the patient must meet the American Thoracic Society standards for volume exhaled in the course of the test. If less than 90% of the previously measured FVC volume is exhaled, the patient is probably not cooperating with the test administration. The message to be gleaned from these comments is that the examining physician should use a critical eye in evaluating test results. The actual test curves inscribed by the pulmonary function equipment should be examined, and the physician should not be a slave to the numerical printout produced by the computer.